This record is going to show you this is the lamina of L4, this is the lamina of L5, this is the L4-5 facet joint, this is the midline, the spinous process, the SAP of 4, the SAP of 5, IAP of 4, SAP of 5 forming the facet joint. This brown is the ligamentum flavum. Now let us assume that we are doing a surgery for lumbar canal stenosis at L4-5 as a traditional posterior midline open surgery. So what we do is we take a cut here and we erase the muscles from this area, from the lamina and from this area, so that we are now exposing the ligamentum flavum, which is lying interlaminar in this area. Now let's say that we have removed the spinous process and we are now coming closer to the removal of the lamina. Commonly, what is done is we commonly remove the upper lamina, that is the lower border of the upper lamina, so as to expose this ligamentum flavum upper attachment, and then we work on the edge of the lower lamina where the ligament is attached directly. Now here, for the sake of clarity, we are doing it like this. We are removing the lamina till we start seeing some more portion of the ligamentum flavum here. Now here is the ligamentum flavum, which matters in causation of the symptoms, and this is subarticular and tending towards the upper pedicle. Now there is a deficiency in understanding of this portion, which traditionally has been called as hidden zone of McNabb. That hidden zone has remained hidden even today, mainly because the MRI scan protocols do not include the cuts, actual cuts in the upper zone in the routine way. They do not show you the upper zone, so you don't even know that the ligament can extend here. Now let's go further. So what we are going to do is we are going to remove this lower pole of the IAP and the edge of the IAP, or a medial facetectomy like this. Once we start removing this IAP medial facet and the lower pole, we start seeing the ligamentum flavum, which matters, and we immediately start seeing the yellow fat, we start seeing the blue sensory and the red roots here in this model, which actually are intrathecal, and then some of them go out of this foramen and form the exiting nerve. Now all of us know everything below the pedicle forms the upper zone up to the upper margin of the disc. The nerve is fixed in this area, immobile in this area. Now we go further, and here let us say we have done a big medial facetectomy, which is what exposes the ligamentum flavum. Most of us who do the open surgery are very happy with this exposure. We may go further. Here we will find we have removed the IAP right up to the pars, and this SAP is still there. So we say that if we remove this much of IAP or the medial facet, theoretically here we have removed it completely, then we are able to expose the important part of ligamentum flavum. And we go further where the ligament is now completely removed, and further where we see the lateral edge of the dural sac, where we completely see on the floor the Cambian's triangle form by the exiting nerve and the lateral edge of the dura, and somewhere here would be the upper margin of the disc, which is similar to this upper tip of the SAP. We go further, and then we find that we are able to clearly see the Cambian's triangle, the exiting nerve, the traversing nerve, or the thecal sac. We go further and further and further, and we find clearly now three things. Number one, above this margin of the disc from here to the lower border of the pedicle is the upper zone of L4. This from here to here, the margins of the disc, is the middle zone canal, and below this is the lower zone canal. Now just to quickly see where we are when we are talking about the middle zone canal, we are somewhere here behind the disc, and you will find when we go on building the interlaminar window, we are much more below the disc than what we think we are. So here the matter here below the disc would be much more important for the interlaminar axis. Now the same thing we'll be doing here, that is we are trying to do a medial facetectomy, expose this ligamentum flavum. If we look at it from an oblique view, we find the nerve is much away, the disc is anterior, this is the operculum of Forestier. Here we will find it from inside where we are, and you will find that we are much posterior to the dual sac here. We are below the IAP, or we are below the medial facet and closer to the lower polar facet. Now let me again build it up towards the dorsal aspect, and we will find this is oblique view of the ligamentum flavum, which our surgeon colleagues who do over the top clearance, they are tackling this. But here we are completely missing the part which lies in the upper zone, which forms the roof of the foramen. Now here you will find, if we build it further, this is the oblique picture, further and further and further, and you will find that we may have to remove so much of bone to just see that ligamentum flavum, and that's what we do in open surgery. Now this would be another view which is coronal, this would be sort of foraminal view, where all these things are happening inside the body of IAP. So theoretically, removing the SAP here, undercutting the SAP here doesn't make any difference to this ligamentum flavum, and the talk of foraminoplasty as a solution to lumbar canal stenosis doesn't work. I hope this point is clear, that this ligamentum flavum is medial to the IAP and cannot be reached from the foramen like this, and this is medial to the IAP and can be reached very well, but only when we cut the SAP, not the SAP but the IAP in the open surgery, and a part of the SAP in the transverse entry transforaminal work. Let me clarify this again. If you want to remove this ligamentum flavum open, we do the medial facetectomy, expose it like this and remove it from here. If we want to do it transforaminal, it may be difficult to reach that area, but we can attempt at going for the tip of the SAP here and then go inside. But please remember, it is not possible to reach this portion, the one which is seen here, very properly by a transforaminal present day available system, and that is the need for a new system which will tackle this part of the ligamentum flavum by coming through the foramen. Our new system is what does that, and it complements the traditional lower foraminal access or a middle zone transforaminal endoscopy is complemented by upper zone transforaminal endoscopy, and we are able to tackle this structure.